As a quick reminder, and I refer you to previous videos for more details, the HFpEF program had two different trials, HFpEF in obesity-related HFpEF without diabetes, and a sister trial called HFpEF diabetes in obesity-related HFpEF and diabetes. They had a combined 1,145 patients. I will quickly review them and then describe a couple of important sub-studies. HFpEF accounts for more than half of all heart failure cases, with majority of whom are overweight or obese, with few efficacious treatments available. The obesity HFpEF phenotype has unique clinical and hemodynamic features and is associated with an especially high burden of symptoms and functional impairment. Semaglutide is a potent once-weekly GLP-1 receptor agonist which produces substantial weight loss in individuals who are overweight. There are many potential mechanisms to postulate the benefits of semaglutide in the obese phenotype of HFpEF. They include both weight loss-related mechanisms on the right of the screen and weight loss-independent mechanisms on the left. 529 patients were randomized to either subcutaneous semaglutide with a target dose of 2.4 subcutaneous once weekly versus placebo. Subjects were treated for 52 weeks with a 5-week follow-up. The semaglutide group had a significantly greater improvement in their KCCQ score compared to placebo. At 52 weeks, there was an estimated difference of 7.8 points in favor of semaglutide versus placebo with a p-value less than 0.001. The secondary primary endpoint was change in body weight. Again, there was an early benefit with semaglutide amplified as the trial went on. At 52 weeks, the estimated treatment difference was 10.7%. Patients treated with semaglutide also had significantly greater improvement in the 6-minute walking distance with a treatment difference of 20 meters. Switching to the HFpEF diabetes. Type 2 diabetes is highly prevalent in patients with HFpEF and is characterized by a more severe phenotype with greater symptom burden and worse functional status. As you just saw, the HFpEF trial showed that semaglutide significantly reduced heart failure-related symptoms and physical limitations as well as body weight in patients with obesity-related HFpEF who did not have diabetes. The HFpEF diabetes trial was the first to investigate the effects of semaglutide in patients with obesity-related HFpEF and diabetes. 616 adults who had documented HFpEF and diabetes were randomly assigned to either semaglutide with a target dose of 2.4 mg sub-Q once weekly or matching placebo treated for 52 weeks. The semaglutide group had a significantly greater improvement in the KCCQ score compared to placebo. The improvement was noticeable around 20 weeks and progressively amplified through the course of the trial. Estimated treatment difference between the groups of 7.3 points in favor of semaglutide. The second dual primary endpoint was change in body weight. Again, there was an early benefit with semaglutide at 52 weeks with a treatment difference of 6.44%. Less than in the HFpEF trial, but still significant. There was a significantly greater improvement in the 6-minute walking distance at 52 weeks, with 14.4 meters greater in the semaglutide group. Now on to an atrial fibrillation sub-study. Obesity is a key factor in the development and progression of both HFpEF and atrial fibrillation. Whether the effects of semaglutide in this patient group differ in patients with and without atrial fibrillation was examined in a pre-specified plan of the STEP program. Here are the baseline characteristics of the patients with and without atrial fibrillation. Patients with atrial fibrillation were a bit older, had features of more severe heart failure, including higher NT-proBNP, with a slightly lower ejection fraction and more likely to be treated with diuretics, MRAs, and antithrombotic agents. One of the dual primary endpoints was KCCQ clinical summary score. This was improved by 7.5 points in the STEP program, which was highly significant. You can see here stratified by the history of atrial fibrillation. Both groups benefited with semaglutide. However, the effect was much larger in patients with atrial fibrillation with a highly significant p-value for interaction. This was maintained regardless of the subtype of atrial fibrillation. There was no difference in semaglutide's effect on body weight based on a history of atrial fibrillation. Looking at 6-minute walk test, which was improved in the overall trials, there was no p-value for interaction based on baseline atrial fibrillation. The hierarchical composite endpoint win ratio was positive in the overall trial, with an even stronger benefit in patients with a background of atrial fibrillation. As you can see, the p-value for interaction is positive. So in conclusion, 45% of patients in the HFpEF program had atrial fibrillation, appeared they tended to be older with features of heart failure. The benefits of once-weekly semaglutide were consistent across endpoints in people with and without AFib. However, the magnitude of benefit was more pronounced in patients with atrial fibrillation versus without atrial fibrillation, without any safety concerns. Switching to inflammation, the adiposity inflammation axis is considered to be a key driver for HFpEF pathobiology. In this pre-specified pool analysis of HFpEF, the benefits are analyzed according to the category of inflammation assessed by CRP. Here are the baseline characteristics of the pool HFpEF program by CRP levels, less than 2, 2 to 10, greater than 10. Participants with higher levels of CRP were more likely to be female, more likely to be younger, and more likely to have a higher BMI and waist circumference. They had similar levels of ejection fraction and NT-proBNP, but appeared to have a higher burden of heart failure symptoms with a high use of loop diuretics. For the first dual primary outcome, the KCCQ by CRP category, semaglutide showed large improvements in this outcome consistently across all categories of CRP, with no significant heterogeneity. As well, no differences in heterogeneity was found in the second dual primary outcome, which was change in body weight based on CRP category. There was also no difference of heterogeneity across key secondary endpoints, including 6-minute walk test, the win ratio, or NT-proBNP. There was also no relationship of weight loss with CRP reduction. The magnitude of CRP reduction was significant, but similar across people with different levels of weight loss. Collectively, these findings suggest that the disease-modifying properties of semaglutide in obesity-related heart failure with preserved ejection fraction may not be fully explained by its effect on reducing CRP.